All right. So I'm Buhariwalla, and I looked at patient communication at discharge. So discharge from hospital is one of the most dangerous times for patients. And my QI team was made up of inpatient and outpatient providers, as well as some patient family advisors. So together we decided that the biggest issue with hospital discharge was communication with patients around discharge plans and discharge medications. The Society of Hospital Medicine has named 7 elements for communication to patients that are considered required for optimal discharge. So my aim statement is that by July 2021, 100% of the patients discharged home from our unit will be provided with all of the crucial elements required for safe discharge, both verbally and in writing. Major themes that lead to poor quality discharge instructions include lack of standardized expectations for providers, provider beliefs, and provider availability or time constraints. So this is my driver diagram, as well as my change ideas, but in the interest of a 3-minute presentation, I'll highlight 2 of the primary drivers. The current discharge communication tools for patients are essentially a blank form, so they're entirely provider dependent, and redesigning our standardized communication tools directly affected a number of our secondary drivers. So this is where our QI team decided to focus our efforts. Unfortunately, the hospital culture is that nobody really wants to own overwhelmingly complex problems, and everyone assumes that what's not being done by them is being done by other people. A rough process map showed that unfortunately this isn't the case, so there's a lot of room for improvement. When I did a chart audit for patients who had been discharged home, none of the discharge instructions contained all 6 crucial elements for optimal discharge, and actually 10% had no discharge information provided at all. And items that were the most often omitted included discharge medications and return to care instructions. So a survey went out to the accountable care unit hospitalists and patient family advisors. And interestingly, both groups thought that communication about discharge medications and return to care instructions were crucial pieces of information. And remember that these were the 2 elements most frequently missing in the audited charts. Most PFAs felt that instructions should be provided verbally and in writing, while 50% of hospitalists felt that one or the other would be fine. And most hospitalists believed that community pharmacists should be the ones to review all medication changes, whereas only 20% of PFAs, based on experience, considered their community pharmacists to be a good resource to explain changes made in hospital. So now we're piloting a discharge communication form on 4A, and it's been designed to include all 6 crucial elements required for optimal discharge, and it also includes a patient-friendly medrec. So once we've worked out the kinks in our new form, we plan to expand this to other units. We would like to get to a place where we can begin the discharge process 3 days before discharge and involve more members of the interdisciplinary team in completing and reviewing the form with patients before they're discharged. We're doing ongoing chart audits, and we'll have data for 7 and 30-day readmissions from before, during, and after implementation of our tools for future run charts. And future plans include development of an interdisciplinary discharge checklist and a post-discharge phone call to patients. So on our ACUs, we provide standardized care delivered by the interdisciplinary team, but discharges are very complicated. So thank you very much to the CQIP team for giving me the tools to get organized, dig into the problem, and actually start to improve the quality of our discharges.